Hello, everyone, and thank you very much to Soft UK for asking me to join you today. My name is MacFadyen. I'm a paediatrician. I retired from acute paediatrics at the end of 2017, and in July of 2020, I became the clinical lead for a network called the Children with Exceptional Needs, or SEN network, in Scotland. And my background and association with SOFT has dated back to its birthday, right back 30 years ago. And at that time, I was asked by a colleague in Leicester, where I was working as a senior registrar, to help him as a clinical geneticist who was seeing families who had had a baby with trisomy 13 or 18 and who were struggling because they had been told when the baby was born that the baby's condition was one that would not allow the baby to survive for very long, and they were either home or in hospital waiting basically for the baby to die. And the parents seeing Ian for genetic counselling were telling him that some of the babies had not died and they were looking after their babies without anyone in the health professions appearing to be prepared for their baby's needs and for how to advise the parents to care for a baby with very complex disabilities. And so I met with some of the families and the parents and agreed with Ian that these babies were needing a very complex combination of care, but basically, most of all, they needed to stay as part of a confident family, and for parents and brothers and sisters and other members of the family to feel that they were doing the right thing for their babies and later for their children. And so I became involved with Soft UK and was increasingly impressed by the way that Soft UK took on the challenge of improving the care for the babies, the children and their families. And particularly, we're very practical about it, accepting that every baby, every family is different, that most families will find it helpful to share and support each other. So giving what's called now peer support, family to family, and being very practical about the range of right answers, that there isn't a single right answer for any one individual. There may be a range of options, and it's important that the options are known, but to accept that what's right for one person may not be right for another, and particularly decisions made by parents in the antenatal period or the neonatal period about what would give their baby or their child or their fetus the right next step. And that's difficult. And very often it's something that professionals find difficult, just as parents do. And so, as I say, I've been impressed by SOFT all the way through. And to some extent, that was one of the reasons that I was keen to work with the SEN network. And so just to tell you a little bit more about SEN, CEN is Children with Exceptional Healthcare Needs. And it is a network that was set up by NSS, that's National Services for Scotland, aiming to ensure that the children with very high dependency needs, with high levels of disability, are known in Scotland to their healthcare providers or health services, and that there is the best care that can be given to the child and their families, and that it's equitable across the country. And equity or fairness is something that has always been important to me as an individual. So I was very keen to work with SEN. I was involved from when it started in 2009. And we aim to try to improve services and to work in partnership supporting families. The SEN criteria are those that apply to a relatively small number of children between nothing and 19 in age, including dependency either on ventilator support or tube feeding and or intravenous feeding, along with other significant disabilities. So there will be some children who have these technology needs, but are otherwise able to function independently and would not be included in our criteria. But many of our children are children with the kind of combination of disabilities that you see in children with trisomies 13 and 18. And so our aim is to improve or optimize the healthcare that these children can receive and that their families can receive. And we do that through a number of aims. We have groups that come together to draw up our priorities. We had a strategic planning event to identify what current service users and service providers see as their priorities. We develop educational resources. We've made 3, well, we're in the process of the 3rd e-learning modules, and we identified their topics on the basis of parents' views of what they needed when their child had complex needs. And so we've headed them communication, coordination, and compassion. And we're trying to highlight how those principles might be better applied for children and families. So we're moving ahead on that. But we are really trying to ensure that when we talk about partnership with parents or partnership with patients, when the NHS talks about that, we truly do mean partnership. And I think one of the things that I found when I worked with Soft UK as one of their medical advisors was trying to just keep people well informed about each other so that there's a better understanding of the words we use, the priorities that we have, and the rules that that we have to work to as health professionals. And I think that's something that is possibly underestimated at times, that people are less aware of what is leading to someone's decision. It's not necessarily a personal decision in a healthcare provider or a healthcare professional. There may be professional requirements or legal requirements that they have to work to, as well as their own awareness of their abilities, what they can offer in the way of care, and their awareness of other people who might be helpful. And as the lead for the coordination module on our e-learning, I can see that coordination is a huge challenge for both the professionals and for the families. And so I felt that today it might be of interest to you as families of children with trisomy 13, 18 to just talk through some of the learning that I have acquired over the years, and perhaps is less easy at an earlier stage in professionals' careers. Although I would have to say that one of the most useful groups, I think, to parents of children with complex needs are senior trainees in all the specialties, because these senior trainees are generally very enthusiastic. They've been very aware of the latest evidence, the latest research, the things that are happening in pediatrics. They are perhaps slightly less constricted by specialisms, so they still have their general awareness, and they're trying to learn. They're still wanting to learn more. And just as I was when Ian Young asked me what should he do, and I didn't know, but I was going to find out, the same thing often applies to the senior trainees, that they are willing to take on board other people's expertise. And so don't feel that because you have a quote trainee that they're practicing on you. It's more that they will use the expertise they have and try to find someone else if they don't have that expertise. Once you get into the specialisms, you have people who are very expert in a specific area of medical care or health care, but they may not be as up to date in other areas. And so it is, I think, helpful to have an awareness of what this person can offer you and your child, and what they might not be able to offer, and not to expect, if you like, too much of them. Although that's hard to say, and some people do have a much wider range of knowledge than others. But thinking about specialisms, and again going back to coordination, and thinking about how many people you as parents have to coordinate with, it is useful, I think, to have a sort of forward plan of how to get the best from each of the many people that you may encounter, and how important your voice is, and your expertise and expert knowledge of your individual child, because every child, every parent, every family is different. And if you think of that in terms of the health professional, they are trying to make sense of all those individual needs. So picking out the bit that you want from them can be helpful. And I've thought about it in terms of the current jargon, and thinking about nudging, and nudging the professional to accept the needs that you're presenting to them in the area where they can actually help. And you may have 6, 7, 8 different specialties to work with. So I'm not suggesting that this is easy, but I think if you do find that you're struggling to get the next step that you need, then it can be quite helpful to think, what is it that I want this particular specialist to give me or my child? And because your children are not in any way typical or average, they're all very, very special, and they all show their symptoms and their problems in very individual ways. And so you may find that you are the expert in interpreting what your child is feeling and wanting to communicate, and trying to distill that down into what can be explained in a clinic can be quite tricky, and using help can be really worthwhile. So talking to people who help your child and help you to help your child, trying to get the words that will make sense for the health professional, and then making sure that those words are accepted, are listened to and understood by the professional, which sometimes means using medical type words, medical jargon, if you like, but actually it's sometimes actually more effective to use straightforward plain English, because using a medical jargon word can sometimes make the professional think that that word is what they're dealing with. And if you've not used the right word, then you put them off on the wrong track. So we found this around me when I was working with children with respiratory illnesses, that people understood the word wheeze in many different ways. And if the word was used in a symptom, if a parent said, my baby is wheezing, immediately the doctor thought the parent was talking about the wheeze in the way that they understood it, while sometimes the parent was using the word wheeze for a different noise, and one which had a different medical meaning. So very often it's most useful just to describe things in plain English in the way that you have experienced them. Because going back to the SEN network, we have we are setting up what we're calling a group of experts by experience, and those are parents and carers of children with complex needs, who will tell us what we need to know that we don't know as health professionals, and be involved in creating learning materials and setting up resources that would be useful for health professionals who are supporting families. And we really mean experts in a way that no health professional can be unless they themselves are parents of a child with very complex needs. So when we talk about partnerships, and it's very trendy at the moment to say we're partners with patients and partners with parents, and what we mean by partnership should be a joint initiative, a joint effort, that we're not saying that we're the same, that we're equal partners in terms of equal knowledge, but we are saying that we depend on each other to get things right. And you can think about it in all sorts of partnership settings, whether it's in a marriage where neither partner does the same thing, but together you're stronger than either one alone. And really that's what we're trying to do in the SEN network. So when you're in a clinic with a health professional, you are the expert in your individual child and your individual child's symptoms and ways of communicating. The healthcare professional is very unlikely to be as expert as you in the communication with your individual child. And so interpreting for your child to the health professional helps them to then share their expertise in a way that is most helpful for you and your child. So it's an expert specialist in the medical side of the information and an expert specialist in the individual child element of the consultation. And between you, you get the information that is genuine and that can be shared. From there, a decision then needs to be made about next steps. And that again is not the same for everybody in the room. Whether you go back to the antenatal clinic, and now we have antenatal screening for trisomy 13/18, and back then you are the person who is being cared for by the health professionals as the mother and father of the baby. And so the information that you're given is about your decisions for you as individuals in relation to the baby that's developing inside mum. So the fetus does not have any rights at that stage, but parents do. And the decisions then have to be based on what's right for you as parents, and the healthcare professionals seeing you in an antenatal clinic are making their decisions on your needs as individuals. Once the baby is born, the baby becomes a patient, and the baby has rights, and those rights are legal rights as well as philosophical rights, if you like, and moral rights. And so the baby's best interests and the child's best interests become the priority for the health professionals and the responsibility of parents. So the information that you're given and the options that you're given will be different at different stages. And again, when I go back to the SEN network, we're working through the care pathways for the children with exceptional healthcare needs from the time of birth, from 0 up to the end of their age 18, to cover the time that the WHO defines as children. So we've said nothing to 19 is the age range. And we're dividing up our care pathways into age groups, really to try to identify getting back to the coordination challenges that are likely to be faced by the families as they go through a lifespan for children with exceptional needs who are likely to be surviving much longer than they did in the past. And going back to my association with SOFT, one of the things that we have learned together is that giving a prognosis in terms of duration of survival for babies with trisomy 13/18 has changed over the years. And that really goes back to those parents who were saying, I was told to take my baby home to die, and the baby has not died. That there were many things that could be done to allow these babies to survive. And the babies are now surviving more often into childhood, and childhood to adolescence, and adolescence to young adulthood. So their needs are changing over time. And the SEN network is trying to address what those needs would be as children survive longer and longer. And we're now at the challenge of transition, which is a time when young people are moving from childhood into adulthood, and where we find that adult services are very little prepared for the needs of some of these children with very complex needs, including those with Pathausen-Edwards syndrome. So that is one of our network's biggest challenges, and where the coordination links up with a whole different set of professionals, some of them very little prepared for what these young people are going to need, and many of them less prepared for the advocacy role that parents or guardians are going to be playing. And part of where we think our experts by experience are asking for help is to know how to navigate their way through the complexities of transition, where a whole new set of professionals come into play. And for me, as a professional, I have realized how little each area of professional work is aware of how other groups work. And so the coordination has been a huge learning curve for me. And one of the things which I think needs to be publicized more is how different titles are used in different areas, and where, again, a little bit like I mentioned about using the word wheeze, we might use the same word for a professional who does a completely different job in a different area or in a different part of healthcare, for instance, between children's services and adult services. And one of my big learning points in the last year has been finding the expertise of learning disability nurses who work in adult care in a very different way from the way that I had been used to in pediatrics. And so where I thought I knew what a learning disability nurse did, I find that I didn't. I knew what some learning disability nurses did, but I couldn't generalize. And then I found in some ways the same applies to a lot of the other professionals. And so the descriptions that you might read, or more importantly, the descriptions that the health professionals have been taught, may actually not apply in a specific environment. And so again, and I can only sympathize with parents who are trying to make sense of all of this, it is important to clarify who does what, whatever their title is. And similarly for third sector organizations, what do they do and what can they offer me where I live, where my child is going to be looked after, where the child may be going to school, to actually find out not so much who's there, but what's going to be done and who's going to do it. And whatever their title is, it's important that you know as parents who does what in your area. And one of the final things which I think is important to share is something that is in the background, but perhaps not clarified in a useful way for parents. And it's around the autonomy question that comes into clinical ethics. And sometimes I think decisions being made are so emotionally fraught that the recognition of clinical ethics can be quite difficult to understand. And I've seen this again, I've learned through SoftU casework. Sometimes a practitioner, a health professional, may be making a decision which legally they are required to make in what's called in the child's best interests. Now, who decides what those interests are should be particularly the child's voice, the child's way of communicating, helped by those who know the child best and have responsibility for the child. And as we go through transition, the autonomy of the child into adulthood is governed by legal rules, which are slightly different between Scotland and England, but are generally acknowledging that the child moving into adulthood is moving into a more independent level of maturity. Now that is again very unique from one young person to another, particularly those who have learning disabilities. And so the assessment of that autonomy and the assessment of the communication that the young person can make about what they feel themselves is their best interest has to be considered, and the best decisions made on that basis. Now, both the parents or the guardians and the health professionals are expected to have the child or young person's best interests as the priority in making decisions. From the health professionals' point of view, and particularly for the doctors or surgeons or specialists, their clinical ethics rules and their legal rules through their profession is that they should aim to do good, to help and improve the health of the individual, should not do harm, so should only take action when it is aimed to improve the patient, and have recognition of the patient's autonomy. Now, sometimes what might do harm holds a clinician back from taking an action that might seem to the parents or carers to be one that would be in the child's best interest. And so an awareness of where decisions come from and how decisions are made, again, is going to need true, genuine partnership and an openness to each other's skills and an acceptance of each other's ability to do the right thing for a child or young person. So I think we as health professionals depend on you as people in organisations like Soft UK, who are genuine experts, who have taken forward the care of all children with complex disabilities. And I hope and wish you every success for your continuing improvements in the care that you and we can offer to children who have trisomies 13 and 18. And I wish you all the very best. Thank you. Bye.